So good afternoon, everybody. Welcome to this session. There's more room out the front here if you don't mind sitting on the floor. I'm really, really sorry about this. My name's Michelle Chu, Professor in Anesthesiology and Intensive Care at Karolinska Institute in Sweden.
I'm Xavier Monnet. I'm Professor in Medical Intensive Care in Paris, France.
Great. So welcome. I know it's been a long day. This is very much an interactive session. We've prepared a case for you today, so let us know what you think. Can we just have the first slides? Right, so an ARDS patient with right heart failure. Jeez, thanks for it. So we have Mr. MN who comes in. He presents to your ED, shocked. He has acute respiratory failure. He has clearly mottling. We know that he was previously healthy, non-smoker. He's been vaccinated for COVID and influenza, and he has a 5-day history of fever, cough, and unilateral crackles. So I'll just go back with his monitoring. You can see that he is hypotensive, he's tachycardic, his respiratory rate is 27, and of course that mottling again. His chest X-ray, you saw that, I just flicked through it very quickly. SpO2 is 98% on 15 liters on a rebreather mask. He's not had any vasopressors, not had any fluids yet. He's cold and clammy, and his capillary refill time is 7. So, what do you think about this patient?
Who wants to comment on the hemodynamic status? What do you think about the patient?
For sure it has signs of shock. We don't know anything about lactate, but based on clinical examination. He also has a very low diastolic blood pressure, which can suggest that this patient has vasodilation. And given the clinical context, probably is a septic shock secondary to pneumonia. Probably.
I totally agree. Of course, I would add that this is life-threatening hypertension. I don't know if there is a limit for defining life-threatening hypertension, but for sure that you must do something immediately. You say two things. First, you do not need lactate initially to know that's shock. Second, diastolic blood pressure is a good indicator of the arterial tone. No need for calculating any systemic vascular resistance. It's physiologically related to the arterial tone.
Okay, I'm sorry we don't have any arterial blood gases, but you do a focused bedside transthoracic echocardiography that shows this. So this is a man with a reasonably sized ventricular chambers. The right ventricle is not dilated. The left ventricle appears to be normally sized. You see some smoke in there suggesting that the flow is not great in the left ventricle. You see that the mitral valve is not opening completely. So without having a cardiac output monitor, can you tell me what the cardiac output is in this man?
It is.
It's low? Does
Low.
everyone agree? Yep. Okay.
You've seen the mitral leaflets just slightly opening, yes.
Okay, and of course we are all intensivists, so we all love the subcostal view, right? So the subcostal view shows that he has a dilated inferior vena cava that is fixed. Now, did you expect that?
Who wants to comment on that? IVC in the subcostal view. You want? Do you think it's normal? This is what you expected? The patient is spontaneously breathing, right?
Still
Michelle?
spontaneously breathing, yeah.
You wouldn't expect in a patient with septic shock.
Why?
Because we are classically thought that they are hypovolemic and vasodilated and they are in a hyperkinetic state.
This patient received no fluid until now, so you expect hypovolemia, at least relative hypovolemia due to vasodilation, and perhaps some fluid losses. So indeed, you would expect a collapse of the IVC even if it's under spontaneous breathing, and we know that it has a diagnostic value if the patient is ventilated, but at least typically we should have an IVC collapse. I do agree with you.
I'm not even sure if the tricuspidal valve is really closing and if this might cause the cava which is expanded. It looks like a severe tricuspidal valve insufficiency.
Really, really great pick. So this was a previously healthy man. Now the right ventricle doesn't look dilated, but we're not optimizing it for a right ventricular view, right? So this is not an echocardiography session, but that was a great pick. The tricuspid valve doesn't look like it's fully closing, suggesting that there might be increased pressures on the right-hand side. Well done. What would you do next? Would you insert a central venous line? This man is still in ED. Would you take him to ICU immediately? Or would you intubate him immediately because maybe he will not make it to ICU? Or would you give him another 500 mils of crystalloids? Would you start a peripheral noradrenaline infusion? Or would you start vasopressin straight away? Would you start dobutamine? We see that his ventricular function is not optimal. Or would you even start low-dose levosimendan?
And we speak about the treatment right now, okay? The patient is still in the emergency department with that cardiac function, this blood pressure, under spontaneous breathing. Who wants to give his opinion, share with his or her opinion with us? Just simply,
there are no right and wrong answers because everyone's, we all do things differently, and it's 4 o'clock and this man is in extremis. Come on, we've got to make a decision.
We may choose at random. I was. Okay. Yes, please. I'm sorry.
Well, since he has a very low diastolic blood pressure and...
Keep the mic really.
He has a very low diastolic blood pressure and...
Sure.
Well, we just saw that the vena cava is very dilated, so maybe we wouldn't fill him up on crystalloids only because, well, we are very careful in this situation.
No more fluid, yes.
Exactly, but we would like to kind of get a vasoconstriction, so we would start the noradrenaline and
so it means that you would start norepinephrine after only 500 mL of fluid at this so early phase, which means, by the way, that you would give it on the peripheral line.
Yes.
That's what you want.
Yes, I would do that right now.
Would you all agree with this? Who says no? You want to say no?
Yes, but because I'm thinking of my emergency room and my resources setting in the emergency room with this.
Where do you work?
In Sweden. But
it's a low-resource country.
Anyway, if you have this kind of patient down in the emergency apartment and you start this kind of therapy, what he needs, I would call my ICU and with emergency medication try to get him up to the ICU.
That's a very practical point, indeed, but we need to start something right now. I think that transporting the patient to the ICU with this blood pressure, I don't know where is your ICU in your hospital, but I would prefer to increase blood pressure slightly before transfer.
Yes, but he did get 2 liters of Ringer and still has the same blood pressure, because on the slide before it showed 2 liters of Ringer had gone in and I had no effect. And then this time I would have epinephrine in diluted, that we have 0.01 milligrams per kilo. That would be our approach, because to have a pump, infusion pump going in the emergency department at that point is a problem.
A bolus injection?
Maybe, yes.
So you're talking about a kick adrenaline, 10 micrograms as a bolus.
5 to 10 to see if he answers to that.
Okay. Does anybody else use that approach, a kick adrenaline approach? You're nodding? Yes? Anybody else who has that? You also? Yeah.
You want to comment on that or just say yes?
I want to say yes. I work in Sweden as well.
Oh, okay. I don't think we have that. Well,
Oh, these
anyway.
Swedes. That's a typical Swedish way of doing. Okay.
Okay. Would anyone start vasopressin? You would start vasopressin? Where do you work?
In Bucharest, Romania.
Okay.
Well, it's a patient with severe biventricular failure, and hypoxemia increases pulmonary pressure and for sure aggravates the right ventricular failure. So a choice between vasopressin, which does not induce pulmonary vasoconstriction, with an inodilator would be better. It's like resuscitate before you intubate. I mean, the patient needs to be intubated, but if we intubate the patient right now, it will probably lead to cardiovascular collapse.
All right. So you're saying a vasopressin with an inodilator, so vasopressin with dobutamine.
Yeah, I think it's a good choice based on the echocardiography.
By the way, bear in mind that there are no studies on vasopressin in ARDS on the pulmonary vascular resistance, only in non-ARDS patients with a different condition. But I agree that perhaps there is less increase in PVR, but in ARDS we do not know. Vasopressin, so you would use vasopressin only and no norepinephrine, or you would start both?
We can start them both, but noradrenaline, at least in this phase, it will also have some beta-1 effects, which would be good for the patient.
It has a small beta-1 effect, inotropic effect indeed.
Yeah, but maybe at a maximum of 0.25 noradrenaline, and after this start vasopressin.
Other opinions on that? Vasopressin immediately? Is someone shocked by that, if I may say?
No central line.
I would take that patient immediately to the emergency room, put the central venous catheter, and start the butamine and noradrenaline.
Okay. The butamine immediately? The only problem with the butamine is that it's also a vasodilator. So starting it with a so low blood pressure may be, personally there is no guideline for this, but I would start norepinephrine now, and then perhaps, depending on the response, start the butamine, looking at the response and taking into account the small inotropic effect of noradrenaline. But taking the risk of vasodilating this patient now, perhaps it's a bit dangerous, no? Noradrenaline in any way, okay.
So I would do that. I mean, this is exactly what we did. We started peripheral noradrenaline infusion in this man to buy time so that he can get up to ICU. And we called up to ICU telling them that, get the central line ready, get the respirator ready, start a vasopressin a syringe pump, and start a dobutamine syringe pump. That's what we did.
And what about intubation of the patient? You intubated the patient a bit later. Would you intubate the patient right now? Of course, it depends on the respiratory distress, right? But why not?
Because he would crash after the induction, resuscitate before you intubate.
Intubating a patient with a so low blood pressure is definitely dangerous. We all agree on that.
And with a so low blood pressure, with that kind of right ventricle.
And with that kind of right ventricle, indeed.
Yeah. All right. Shall we... and would anyone start levosimendan?
What would be the advantages of levosimendan, Michel, compared to the butamine?
Well, I guess it's if we assume that this person is maximally stressed and has a real cathecholaminergic response, you could argue that part of that picture, that cardiac picture, is a stress cardiomyopathy. So that would be the only reason why I would think about levosimendan. But would I do that? And the answer is no. You need to try your noradrenaline. Once you put in levosimendan, your blood pressure will fall, and it will be a profound decrease in blood pressure, for which you would have to start a quite high dose of noradrenaline. Yeah.
Do you disagree with this, Peter?
Thank you. No, I do not disagree, but would you consider giving milrinone instead of dobutamine?
Yes, I would. I would consider giving milrinone, but I would try dobutamine first at a very, very low dose. Yeah. Okay.
We have a question here, Michelle.
Would epinephrine as a perfusor low dose also be an option to increase blood pressure and inotropic therapy?
It's difficult to as you know, it's not a good recommendation. There is no recommendation for epinephrine as a first-line agent. The first reason is that this may induce excessive vasoconstriction compared to norepinephrine alone or norepinephrine plus dobutamine, especially in the splanchnic compartment. There are no clear human data on that, but that's an argument why it's not recommended as a first-line agent. There is another argument which is that you may be interested in having two different buttons for setting the vasopressor and the inotrope. In addition, you may be interested in some specific inotropes, as said by Michel, inodilators than levosimendan or milrinone perhaps, which is not a property of epinephrine. So I would not go for epinephrine. But as an emergency measure, if you have nothing else, and depending on the context, why not? Huh? But,
yeah. And, to be honest, there's really no data for any of this. But a physiological reason to avoid adrenaline in this context is you want to spare myocardial energetics, reduce myocardial oxygen consumption. He's already tachycardic at 143. Even with a small dose of adrenaline, you would increase that, and then you could totally tip the patient over to a cardiac arrest. You might save a few minutes, but then the longer-term cost of it is quite high. Yeah. Okay, so shall we move on?
Yeah. Let's go further.
So the patient received 2 liters ringers, start peripheral noradrenaline. Oh, I'm going backwards, sorry.
Otherwise, it would not be very efficient if you come back to the previous
I
echo.
don't keep going back. So now he's in ICU because you've bought time, you've taken him up to ICU really quickly. His SpO2 now is 67%. Despite the 15 liters on the rebreather mask, his mean arterial pressure is now 40, despite noradrenaline base at 0.1 micrograms per kilo per minute. And you all know which type of noradrenaline you're using in your countries?
Tartrate or base? Yeah, you all know the problem.
Tartrate? Everyone has tartrate? Does anyone have base noradrenaline? In Sweden, it's all it's tartrate. All right? So you ask the nurse to start an infusion of dobutamine, low dose, and you prepare for endotracheal intubation. Are you okay with that? No? So, Xavier, what now?
That will be a dangerous intubation in any way.
Yeah.
Of course, you already started noradrenaline, but MAP is still very low. I guess that if MAP is 40, the diastolic blood pressure cannot be more than 35. So it must be low. The patient is severely vasodilated. I do not know the drugs you will use for intubation, but that will be a dangerous intubation.
And this is where the kick adrenaline comes in, because this is really scary, right? So the question is, would you try NIV in preparation for endotracheal intubation? Is that right? Yeah. Who would try NIV? Hands up? Oh, quite a few.
And why not? You say no.
Because we have a patient who is very hypotensive and of a cardio-hemodynamic effect of NIV. It's very dangerous.
I think I would rather go for high flow oxygen therapy and because I still am afraid for the right ventricle if I apply PEEP.
In fact, the deleterious effect of ventilation are due to positive pressure ventilation, either invasive or non-invasive, and that's why you're afraid of a deterioration. So perhaps that high flow nasal oxygen, because mainly the patient is hypoxemic, maybe an option, no?
Yeah, I think HFNO sounds like a reasonable option because I'm so afraid of the right ventricle, okay? So you were absolutely right. Look at this beautiful tricuspid regurgitation. It's not even regurgitation. It's called what we call, there's a special term for it. Not massive, torrential tricuspid regurgitation, right? Because the right heart is dilated. He's received now 4 liters of Ringer's, noradrenaline. This is the base dose of 0.3. We started vasopressin and dobutamine at a kind of moderate dose now. So, Xavier.
And you started vasopressin quite early then, huh?
Yes.
Which is, of course, we do not know when to start vasopressin until now. There are some arguments for starting it early, and perhaps that the effects on the pulmonary vascular resistance may be one reason why.
Yeah. So this is just to show that he has pulmonary hypertension, but we don't know if it's pre or post-capillary pulmonary hypertension until you put your Doppler over the pulmonary valve, and what you see is this, I don't know if you see it, this, in the yellow one, you see this W pattern. Right, that's called the flying W. That is very specific for pre-capillary pulmonary hypertension. Now, of course, you know that pulmonary hypertension can be pre- or post-capillary. So this is a very specific sign for pre-capillary pulmonary hypertension. Probably the ARDS is causing it rather than heart failure. So, Xavier, let's talk a little bit about cor pulmonale.
Acute cor pulmonale, what's the prevalence of acute cor pulmonale in ARDS patients? How much would you say? 20?
20?
The other
20%?
ones?
Who says?
20?
Everyone?
Up to 40.
40%? All right.
Acute cor pulmonale. You all agree?
So even in a setting of low tidal volume ventilation, so lung protective ventilation, the incidence of acute cor pulmonale, and I mean acute, in ARDS patients is about 20-25%. It's a lot more common than you think it is. And if you look for it, you will find it.
That the results come from this study, more than 700 patients, where the incidence was 22. Indeed. I think that, and this was done with protective ventilation at that time already, so reasonable PEEP and low VT, even if VT was not very low in this study. Perhaps that today the prevalence is lower because we use more and more protective ventilation. In my practice, in my unit, it's less than 22, much less than 22. So perhaps we need to reassess that. We have an ongoing study on this. If you want to participate, by the way, just tell me. It's a very simple study, but at least it's not all patients with ARDS. Okay, that's a big problem. And this study showed, Michel, that it's also an independent marker of mortality. It's independently associated with mortality. We all know that these are severe patients, so we should do something against ACP, acute cor pulmonale, in these patients, right?
Yeah, absolutely. And ACP is highly reversible. There are things that you can do to treat it and to prevent it. And things that you go, well, none of this is particularly evidence-based. There's no randomized control study for treating ACP. But we know that risk factors are hypercarbia, for example, hyperventilation.
Which is often neglected. Be aware that hypercapnia is vasodilating for the peripheral vessels, but vasoconstrictive for the pulmonary circulation. That induces significant pulmonary vasoconstriction.
Yeah, and driving pressures as well. Definitely a risk factor for acute cor pulmonale. And from this study, they also propose that you should do routine TEE screening. We don't have a routine TEE probe hanging at the end of our beds, but we can get it. But, to be honest, for assessment of the right heart, the TTE probe is much better. So there is no excuse. So transthoracic echocardiography when the risk score is more than 2. So one of those things, hypercarbia, PF ratio should be less, not more than 150, and high driving pressures. So Xavier, how would you ventilate this patient?
Yes, and indeed, how would you set PEEP in this patient? It's always the problem, how to set PEEP. Would you take into account the right ventricular failure for setting PEEP? How would you do that? You want to answer, or it's not a pitfall, huh? Yeah, that's right.
Maybe I would set a lower PEEP than I normally would in this patient because of the right heart.
Your strategy would be to use the lowest PEEP, right? You would agree? You would agree with this? You work together, in fact, no? No, okay.
Maybe I used to titrate PEEP with echo. Saying maybe
How
the
titrate PEEP, and on what are you looking at with echo?
On the echo, maybe if, a right ventricular bulging, if paradoxal septum.
Okay, so you look at the RV size.
Yes, the RV size.
Setting different PEEP levels.
Yes.
Yeah.
Bedside.
I mean, with echo, you could also calculate the SPAP if you have the CVP pressure and see how the SPAP is increasing. Or
with that tricuspid valve?
Yeah, it's really, really difficult to see.
Yeah.
But you're also thinking that maybe too less oxygen might cause more pulmonary vasoconstriction. That would be, so we need to see how it's happening.
One good point, I agree with you that bear in mind that several factors influence RVP, pulmonary vascular resistance in heart. Something against which we can do nothing, microvascular remodeling or thrombi, but also hypoxic vasoconstriction, hypercapnic vasoconstriction, as we said, and PEEP. So PEEP is not the only factor. Second thing, monitoring SPAP, systolic pulmonary artery pressure, with echo is not that easy. That's why in my unit we use pulmonary artery catheter in these patients. Typically that's a patient where we would use. Yeah. I would just suggest you may just choose the PEEP level by detecting pulmonary recruitment induced by PEEP. Yeah. Indeed, you may know that PEEP affects the right ventricular function through two pathways. First, it is transmitted to the right atrium. It decreases cardiac preload because it pushes against the free wall of the right ventricle, and in case of preload responsiveness, this decreases cardiac output. And the other pathway is that it increases the transpulmonary pressure. It's the pressure that is distending the lung tissue, which means that it stretches the pulmonary vessels, decreases their diameter, and this increases the right ventricular afterload. However, this is not so simple, and that's the big point. In fact, if you look at the pulmonary vasculature, there are two types of vessels. You have some called extra-alveolar vessels. They are in interstitial spaces surrounded by conjunctive tissue. And you have some intra-alveolar or alveolar vessels which are, as you see, stuck between the alveoli through which the gas exchanges occur. And these two types of vessels react differently, and that's important when you set PEEP. Initially, when you increase the lung volume, the first effect is that you dilate the extra-alveolar vessels, and this decreases pulmonary vascular resistance. And when you unfold, let's imagine a completely fold lung. When you initially unfold it, inflate it, you unfold these large vessels. But then, when you increase the pulmonary volume, the next effect is that you compress the alveolar vessels between the alveoli. And this occurs above the FRC. That's why the resulting curve is a U curve, which has been described in animals in the 90s. Okay, you may say that's just physiology, okay, but no, this has application, and especially when setting the PEEP level. Indeed, when setting PEEP, in theory, if you followed me well, it means that if you recruit the lungs, in theory, you should have no effect or even a decrease in pulmonary vascular resistance. On the contrary, if PEEP is over-distending the lungs, in theory, you may increase the pulmonary vascular resistance. You understand? Because of this U curve. And indeed, in this study, we showed that it's the case in patients. We measured the recruitment of our inflation ratio, or of the I ratio. It's a way to estimate recruitability of the lungs. And we showed that in low recruiters, so rigid lungs, if I may say, non-recruitable lungs, when we increased PEEP, we increased the pulmonary vascular resistance, while when PEEP recruited the lungs, PVR did not change. Suggesting it's another argument why we should titrate PEEP depending on lung recruitment. And of course, in this patient, where the risk of increasing pulmonary resistance is very important, that may be a good solution. So my suggestion would be indeed to titrate PEEP. Perhaps the best way is to look directly at the pulmonary vascular resistance if you have a pulmonary artery catheter, but in any way titrate PEEP on lung recruitability because it affects hemodynamics.
Yeah, and of course, this sounds all very easy in theory, but if you don't measure it, you won't know. And don't forget that these changes are also patchy. So what we're measuring here is the total pulmonary vascular resistance and the total effects on the lung. And for those of us who don't use pulmonary artery catheters, because I know that a lot of units no longer use this, don't forget to put your Doppler pulse Doppler wave across the pulmonary valve, because you have that flying W sign, it will disappear, right, very, very quickly. So it's a very good way of non-invasively, and it's just an estimation. It's just it's a binary variable. Is it there or is it not there? But you can use that as a way to monitor the effects of your treatment.
So that's fine. A small summary, perhaps, of what we said, because we just have 1 second left.
So, in summary, we have this patient with ARDS who has no other risk factors. We know that early noradrenaline infusion may buy you time. We also know that intubation in these cases is, we need to do it, but we need to figure out ourselves, and this is locally determined as well, what is the safest way to intubate this patient. We also know that patients like this need some form of monitoring, either with a pulmonary artery catheter or with ultrasound. Actually, it's best combined. In terms of titrating PEEP,
we suggested that titrating PEEP on lung recruitment or recruitability, whichever the way you assess it, is likely a good way to preserve the pulmonary circulation. Finally, we had no time to speak about proning the patient, which may be the best way, or at least a very good way, to unload the right ventricle. That will be the opportunity for further discussion if you want.
That was actually the most important message, wasn't
it? Indeed.
Thank you very much for joining us.